Parminder. It's my great pleasure to introduce Dr. Parminder, who is Associate Prof at PGI Chandigarh and has undergone training as far as the performance and measurement and follow-up of patients with severe aortic stenosis is concerned. And he's going to speak to us today on the most important of the basics, that is the CT imaging and the analysis for aortic valve interventions. It was my pleasure to have been Dr. Parminder's colleague in PGI during my training about 20 years ago. And we've kept in touch since then, and I have watched him grow with great pleasure. And I'm eager to hear him today.
Thanks a lot, Dr. Ajay, for nice introduction. And good evening to all the experts, my seniors, my colleagues, and my dear friends. Today, we are going to discuss CT imaging and analysis for aortic valve interventions. And I thank Dr. Sujatya for giving me this opportunity for this interactive session. So the learning objectives for today's presentation is regarding the CT in aortic valve assessment for TAVI or TAVR, whatever we say. Most important thing, I think, is the acquisition, CT acquisition. We'll be discussing a little bit about that also, because that's the most important parameter. I think if the CT acquisition is not done properly, we can't really help it. We can't really analyze it properly. So first is the image acquisition, then how to determine annular plane and various other measurements which are required for TAVI or TAVR, and what are the common pitfalls in the measurements, and how to assess the appropriate access site for TAVI, and how to report a TAVR CT. We will be discussing all these stuff in the coming slides. So we all know that transcatheter heart valve procedure is a minimally invasive procedure of implanting a prosthetic heart valve. The procedure can be performed using various approaches, like most commonly we do it is transfemoral. It can also be done transapical, transaortic, transcarotid, subclavian, axillary, or transcaval. CT imaging of the heart guides the physicians to assess the feasibility of each approach, as well as perform the measurements recommended for selecting appropriate processes. So first and foremost important thing in the CT imaging is the acquisition. We need to know what are the recommendations, what we need from the CT images, and how to acquire these images, and how to overcome the artifacts or certain limitations which we sometimes get in our scans. So image acquisition data for TAVI CT is acquired in a CT scanner, cardiac CT, may be acquired in any cardiac CT scanner which is available in most of the hospitals. And strategies may vary according to and scanning protocols may vary based on scanner system and the institutional preferences. The key component of all approaches, whatever CT we use, is ECG-assisted data acquisition, which covers the aortic root, and non-ECG gated data acquisition for the vasculature, like aortic and iliofemoral vasculature, which doesn't require ECG gating. So ECG gating basically is required for the analysis of aortic root, like annulus and other measurements only. In the image acquisition, first important thing is the patient preparation, which is often overlooked, but it's very important. Two important things in the patient preparation is that position of the patient on the scanner table should be typically spine, and it should closely resemble the position on the cath lab. Only then we can use angles and other measurements derived from CT data set in our cath lab on the CM, like angulations and other measurements. Second important thing when acquiring a CT is the breath holding. It's very important. Otherwise, if the breath holding is not proper, certain artifacts will creep in, and we may not be able to analyze the CT properly. So due to the advanced age and frailty of this patient population, additional time may be needed for patient instructions. Sometimes most of the elderly patients are hard of hearing. In such patients, if the verbal command doesn't work, we can use some visual commands like switching off the light or switching on the light for breath holding for the scan. The second important thing in the image acquisition is dose modulation. What is dose modulation? Dose modulation is dose regulation. Ideally, if we want good images from the CT, dose modulation should be switched off to allow for data acquisition with peak tube current throughout the cardiac cycle. If we see this figure, this blue bar is the current, is the full tube current throughout the cardiac cycle. So we acquire the images or the data, CT data, throughout the cardiac cycle with full tube current. But the problem with this dose is that the radiation dose goes quite high. So we have to think about the radiation dose to the patient also. So for aortic root evaluation, images are not interpretable if the tube current is lowered below 1/3 of the peak current. This blue bar is the peak current. If we lower it to less than 1/3, the images become uninterpretable. So at least even during the diastole, we should have 1/3 of the tube current, of the full tube current available throughout the scan. Otherwise, for aortic root, we should have full tube current if we want good images throughout the cardiac cycle, or at least during systole. This is dose modulation. It's a modulation of the tube current with peak tube current during the predefined phase of cardiac cycle and lower tube current during the remainder of the cardiac cycle. For example, in this example, we have a full tube current during systole and lower tube current during the diastole. We remember that the data and most of the measurements which we use in TAVI are in the systolic phase. We measure in the systolic phase because systolic measurements of the annulus are typically larger than the diastole. And most of the available processes, they prescribe the uses of systolic measurements for their processes. So full tube current during systole is very important for reconstruction and for image analysis. Otherwise, during diastole, we can modulate the dose. What the advantage of dose modulation is the lower radiation dose. Disadvantage is that if we want to reconstruct the images outside of this full current window, the images may be noisy and may not be interpretable. We must remember that most of our labs or CT angio like technicians, they use protocols for CT coronary angios. CT coronary angio is a snapshot during the diastole. So what they usually do is they modulate the tube current during systole, which is just of the reverse what we want in TAVI CT. So coronary CT angios, it's fine if we modulate the current during systole, but for TAVI CT, we need full tube current during systole to get good images. This is just to show that if the images of the aortic root are acquired at less than full tube current, the images become noisy, grainy, and may not be interpretable as shown image on the right side. So we should use a full tube current throughout the cardiac cycle or at least during systole for image acquisition. Next important thing is ECG gating. ECG gating is required for the image acquisition of the aortic root. It's not required for the peripheral vasculature or the aorta. ECG gating can be retrospective, it can be prospective, or it can be high-pitched helical acquisition. What is retrospective ECG gating? In general, retrospective ECG gating is a technique which is available on all the scanner platforms capable of doing a cardiac CT. It can be performed with a full tube current throughout the cardiac cycle or with dose modulation. And usually, for this retrospective ECG gating, we do a spiral or a helical mode CT, which records the data throughout the cardiac cycle and at a full tube. Even modulation can be done with the retrospective ECG gating also, but there are limitations of doing that. The advantage of retrospective ECG gating is that it allows for dynamic imaging. We can have cines, we can have movies, we can like get the movies from the data later on if required. And image reconstruction throughout the entire cardiac cycle can be done. Suppose there is a some artifacts in the systolic images, we can go back and reconstruct the images from the diastole or some other phase of the cardiac cycle to get our measurements. So this allows for reconstruction throughout the entire cardiac cycle. And there is a greater flexibility in unstable heart rates or rhythms, suppose in atrial fibrillation or premature ventricular contractions, where we may have to reconstruct, go back, and we may have to delete some like beats from where we don't want data. We need to reconstruct the images, maybe sometimes not from systole or from diastole. Then we need is retrospective ECG gating. Further, this provides us ability to use data from different phases and to manually edit reconstructions. And this provides us ability to perform ECG editing that we'll be discussing shortly, for irregular rhythms. But disadvantage of this approach is that it's a relatively high radiation dose, as full current is applied throughout the cardiac cycle. Prospective ECG triggering is another mode where data acquisition is performed in a slabwise manner. While the patient table does not move, here only the systolic phase is imaged with the CT. The rest of the phase, we don't use we don't acquire the images, and we just move the table. When prospective ECG, here we use ECG as a trigger. For example, here in this particular example, in the systole, we provide a full tube current, and in rest of the phase, we don't acquire the images, so there is no current in the tube at all. So image acquisition is done only during systole. The advantage of this approach is that the radiation dose is lower. However, the disadvantage is that it allows only for limited coverage of cardiac cycle and almost no correction in case of motion artifacts or other artifacts. So this method should only be used if there is a concern regarding the radiation dose. Otherwise, most of the CTs are done at full tube current using retrospective ECG gating. This is another approach, high pitch helical. This is a combination of the systems. Here we use two scanners, dual source scanners, where they acquire the data at a rapid speed. The advantage of this method is that it acquires data at a high speed. The whole thorax, abdomen, and pelvis can be imaged in a slightly more than a heartbeat. So it's really quick, really fast. And data acquisition can be done with ECG gating or without ECG gating with this particular view, with this particular approach. The advantage is that the radiation exposure is lower in comparison to retrospective acquisition, but is higher in comparison to prospective acquisition. But it's quite fast, and most of the scanners, most of the hospitals don't have dual source scanners. So retrospective ECG gating is the most commonly used method for data acquisition in our labs, in our CT like departments. So after the ECG gating, another important thing is the amount of contrast. If the contrast amount is low, the image or the scan will be noisy, and we won't be able to interpret it. Most commonly, within normal body habitus and normal imaging protocols, we use 60 to 100 ml. Here in PGI, we do CT in our department itself because we have a CT machine available in cardiology department, and we do 80 to 90 ml, which gives good results. And bolus tracking with a region of interest in the ascending aorta is sufficient for imaging the aortic root. And a minimum injection rate of 3 to 4 ml per second is usually required to allow for sufficient contrast attenuation of the aortic root. And the slice thickness, which we need for most of the scans, is less than 0.75 millimeters, although it depends upon the system capabilities. After we have acquired these images, we need to reconstruct. Most of the machines do it by themselves, but we should know it. In case of artifacts, we can go back and always change the settings in our machines, and accordingly, we can reconstruct it again from the raw data, which is available in the system. For ECG gating, like ECG assisted image data of the aortic root and heart reconstruction technique, there are two techniques available. One is the relative percentage-wise approach. The second is absolute reconstructions. The relative percentage-wise approach, here, multiphasic data set of the entire cardiac cycle, like on the figure in the middle, we analyze the data like in different 10% increments or 5% increments from 0 to 90 or 0 to 95 in a relative percentage-wise approach. ECG editing may be done if necessary, and slice thickness is again 0.6 to 0.75 millimeters. This approach works reliably with retrospective ECG gating in patients with stable heart rhythms. However, if the patient's in AF or patient has BPCs or patient has faster ventricular rates, faster heart rates, this approach is prone to artifacts because then these slabs, percentage by slabs, they will like shrink and the data acquisition may not be done properly. In this kind of patients, the second approach is the absolute reconstructions. Here, what we do, we analyze the data, we reconstruct the data, which is centered with a fixed interval after the R peak. So it's not a percentage of the total cardiac cycle, it's for a fixed period of time after the R peak, usually 250 milliseconds after the R peak, so that we acquire, we reconstruct the data, which is available in 250 milliseconds from the R peak in systole. This method is advantageous in patients who have irregular rhythms, who have atrial fibrillation, who have premature ventricular contractions, because they don't affect the data acquisition or data reconstruction during this period. And for the peripherals, we do non-ECG assisted image data with slice thickness less than 1.5 millimeters. If required, if there are artifacts, and if the ECG shows premature contractions or irregular RR intervals, these can be edited. We can exclude the data from the unwanted periods of time in the ECG or in the cardiac cycle. For example, if there is a premature contraction, reconstruction, the data which we include in reconstruction can be excluded. Similarly, if there is a short RR intervals, that data can also be excluded. So we need data which is the systolic data and which is acquired or reconstructed at regular heart rates so that artifacts can be avoided. And the last thing in the image acquisition is the scan coverage. The scan, we know that we want ECG gated data for the aortic root and non-ECG gated data for rest of the things, starting from the above the aortic arch to below the femoral head, so that we can assess the peripherals also. Here, aortic root is assessed with ECG gated data, and rest of the things are image acquisition is with non-gated acquisition. And these are the protocols that we all have discussed for cardiac CT, and this is for the peripheral CT. This is all we have discussed now. So once we have acquired it, should we discuss questions in the last, or you want questions now, Dr. Achay? Hello. Hello.
Yes.
Yeah, should I proceed to the next?
So just one small question: do we need beta blockers during this acquisition?
Yeah, if the heart rate is faster, then it's better to give beta blockers. Beta blockers stabilize the heart rate. RR intervals become more uniform, and the data acquisition is more uniform and I think artifact free if the rates are controlled. At faster heart rates, we can use the other method, the second method, which is time bound method. But still, I think it's better to have lower heart rates near 60 or 70. It's better if we have it. I think the rate should be adequately between 60 to 80 beats per minute. Hello.
Yeah, please go ahead, Dr. Parminder. I think it's quite it's fascinating because we are so focused on just looking at our images. We don't really see what we're going to do as far as the how the image is acquired. We just
Yeah.
go ahead and get the
Yeah.
city. So I think it's been a
Exactly.
real education. So it's something that we really don't look at, to be honest. We just
I
send
think
them
even
off.
if we see the Tremencio report or any city report or
Yeah.
like a report, what we see in the first top 2 or 3 lines is the image acquired during 30%,
30% of systole or whatever.
30% or diastole. If the images are acquired during diastole, it has its own limitations.
Yes,
Yeah.
that part is absolutely right. But so much I learned about simple things like positioning the patient and
Yeah.
ECG gating and non-gating. We just say
Right.
ECG gating tower protocol and kind of send him
Yeah.
off to the radiologist, and then
True.
we try and make whatever we get out of those images, and we keep thinking that we've done a great job. But I think it was a great learning experience on
Yeah.
actually how to acquire the images. So I think
Exactly.
that is great learning because we don't really look at that part very carefully.
Yeah. And suppose we are getting the artifacts, we can always ask our technician to reconstruct
Reconstruct,
because
yes,
data is there, and we can simply exclude those disturbing artifacts or something like that. We can always reconstruct, and from the same city, we need not to repeat a city. From the same
absolutely.
data, we can always reconstruct it again by applying some other settings.
Yeah, so I think
Oh.
that is possible with the 310 software, that you can actually decide which part of it, which part of systole you want, which image you want to analyze. And if you find it's too artifactual, as you keep doing the CTs and keep analyzing the CTs, you actually learn which is better. But the part of acquisition itself was a great education.
Yeah, exactly.
In fact, I was trying to take some notes because I've decided I'm going to sit in the CT scan and try and see if we can learn a little bit more about it.
Because even Tremencio provides you like a systolic best phase, systolic
Absolutely,
phase, diastolic
absolutely.
phase. Yeah. And you can choose like.
No, we have become lazy actually. Now the system is so really, I'm telling you, the system is so good that it will tell you that these are the best images. And
Yeah.
you just kind of decide whether they're reliable or not, depending on whether they're systolic phase or diastolic phase, that
Yeah.
images are available.
Yeah.
So only
But
now recently I've learned that, okay, if it is diastolic, then I say, okay, show me what is there in systole. And
yeah.
then I will pick the images of the annulus that I need, or, small
Yeah.
things like I will use the systolic for the annulus, and I don't mind the diastolic for the coronary heights and other things. But I will use the systolic if the annulus images are good.
Yeah. Yeah. Exactly.
So maybe we can help to acquire better images. Please go ahead.
Like,
Sorry.
yeah. And like once in a while, what I have found is that I don't know whether that was correct or not, but once in a while we found is that the annulus was larger in diastole in comparison to systole.
Right.
So these days, some people recommend that you measure it in both the phases,
Both
systolic
the
and
phases.
diastolic phase,
Yes,
and
I've heard
use
Vinny
whichever
Bapat
is
also say that. I've heard Vinny
whichever is
Bapat
larger.
say that, whichever is larger.
Whichever
But
is larger.
in my limited experience, I didn't find so much of great difference. It may be just one individual case where the patient is moved or something.
Mhm.
But when I actually sit and see, I don't see so much of difference in the annulus per se.
Yeah.
But the other measurements sometimes do change, especially the coronary heights. So I think that is the most variable measurement, and I'm still struggling to make sense and decide what is perfect as far as the height is concerned, because I think that has a lot of variability in systole and diastole. I think the annulus doesn't change so much
Yeah.
when I'm sitting with it myself. So
So
I don't know
about
what your experience is, but
Yeah,
about
there is.
replicating,
yeah,
sorry, about
yes, Sagatya.
replicating the exact position. The patient is in supine position. Is there any special thing that we have to do to get an exact replica while the patient is lying on the table? Because it's just supine, I think, in both the situations. So
Yeah, I think that's fine, but simply sometimes the patient may give some tilt during the cath lab procedure.
okay,
Some patient
so
may
that's
move. Whenever we are acquiring the data, acquiring the angiographic images, the patient should be stable, should be lie spine, should be flat, totally flat. I mean, we need to be careful. Keep it in mind that this is what we want. That's all. I mean, yeah.
So on a lighter note, I'll just share with you what David Ildick Smith once told us, that the initial towers that they were doing, they didn't have this concept of CT scan. So how they used to be, they had only three slices of valve. And how they used to make the measurement was to do an echo.
Okay.
They would use the echo and use a pigtail injection. And that's it,
Okay.
And with that, they would make all the measurements. There was no question of recapturing and redeploying, etc. You had one chance to deploy the valve, you had
Yeah.
one chance to make the measurement, and that's it. And he says now you go into so much of detail about this height and that height and this angulation, inner curve, outer curve, all those things. In our times, we did the echo. We found these two measurements. That means whatever the annulus was, and the height of the coronary on the angiogram, and that's it. We just went ahead and put the valve and prayed to God that everything went off well. I said, no, I'm sorry.
Yeah,
Times
I
have
think with
changed
the
a
help
little
of
bit.
CT, we are getting into more and more complex cases because we have a CT
Absolutely.
guidance now available. So I think CT is really the keystone for planning the intervention, like aortic valve intervention.
No. I think there is so much of learning that this part has really got kind of missed by. We just get the CT and then we put it onto the 3-menso and then start playing video games with the images. But if you don't
Really, I mean,
have,
I find it very interesting. I find it really a very I will very happy to go through CT.
yeah,
When you
yeah,
I enjoy that. I mean, once
it
you start
appeals,
doing it,
yes,
really.
appeals to your intellect. That I can see, and that it does help.
Okay. So should I move now?
Yeah. Please go ahead.
Yeah.
Please go ahead.
So once we have acquired the data, next thing is the annular plane. What is the annular plane? We all know that it's not a structure, it's a virtual structure actually. It's a virtual ring which is formed by the hinge points of these coronary cusps, right non and left coronary cusp. It's the lowermost basal portion of these cusps. It's where we have to get down to take all these measurements of the annulus, which is important for not only selecting the size of processes, but also for positioning the processes and to avoid other complications. So how to find the annular plane? There are different approaches. One is the manual approach, which we do on our CT machine here using the Siemens software. Otherwise, we have facilitated annular segmentation and semi-automated annular segmentation. The one from Tremencio is the facilitated annular segmentation software. So what we need to understand is that whatever approach we use, the most important thing is the final transverse double oblique view should transect the hinge point of all three cusps. So if you see three images below, you have a image on the left, which shows the right coronary sinus, non-coronary, and left coronary sinus. So this should reflect the hinge points of all three cusps. So this is whatever we use, manual approach or automated approach, this is what we target. And yeah, okay. We move on to this is a little bit complex, but before that, before coming to that, I think let's see how I do it. Sorry for the tilted because I recorded it myself from our city. This is our Siemens city machine in our department. So this is the patient list. We select it, right click it, CT TAVI planning. Once you do that, we get this kind of thing. Then what we need is these are the crosshairs. The game in CT is these crosshairs. That's all. If you learn how to use these crosshairs, you are done. Yeah, I mean, half of your job is done. So these are the crosshairs. We center these crosshairs on the aortic valve. Try to center these crosshairs along the long axis of the aorta, as well as in the short axis in the center of these cusps, in the center. This is tricuspid aortic valve. We see the crosshairs should be in the center. Then we locate coronary. Just let me hold it for a while. This is the hinge point of right coronary cusp. Can you see my cursor? This is the hinge point of right coronary. This is non-coronary, and here we have the left coronary. This is the hinge point. This is what where we want to get down to, right? So the top one at 1 o'clock is the right coronary cusp. At 7 o'clock is the non-coronary cusp. At 4 o'clock is the left coronary cusp. So we need to get down to the hinge points of these coronary cusps to find the plane. They should be just visible, just barely visible. Even I would say this is a little bit at a higher level. We should little bit go down a bit more. They should be just barely visible. And this is a very good test. This is called as the turnaround test. We should come back once we have got the plane. We should come back to this view. We should move our cursor up and down to confirm that, okay, we are at the right place. We are at the right plane. Right? We should move it up and down. All three cusps should appear and disappear simultaneously. Once this is done, then we measure it. We can measure it with the various tools which are available in the machine. This is, we are measuring the perimeter. You can measure the perimeter here. This, yeah. Then you can use other tools to measure the area. This is the area measurement, right? So this will give you area. You have perimeter, you have area. From where you can drive your diameters. And then we can take the two diameters, long diameter and short diameter, and average these two. So these are the annular measurements, right? This is what we want. For self-expanding valve, we use perimeter. For balloon expandable valve, we use is the area. Once we have done that, we go back and this is the annulus. And we can see the other planes like coronal section and the sagittal section, which have now been a little bit modified. And they show the annulus level or the vessel plane from where we can measure the coronary heights, we can measure whatever we want, right? So this is how we acquire using Singovia in Siemens software, which is free of cost, right? And then next is the automated. This is the same thing with Remensho, right? So here in Remensho, what they do is, this is the right coronary cusp. If we see here, this is right coronary cusp. This is non-coronary cusp. And he's already measured the left coronary cusp. And all three dots at the level of the annulus. Again, check it, around, turn round. And we measure these annulus size, or this is the annular plane. This is the turnaround that you need to come back. Once you have identified the plane, you need to come back and recheck it, that it's at the right place. With this plane, now we can determine the fluoroscopic angulation. Usually fluoroscopic angulation is most of the times we are comfortable with using alveocaudal or alveocranial views for the coplanar view and areocaudal for the cusp overlap. This, I think, most of us prefer coplanar view with RCC in the center. As we can see on the right side of the screen, we keep a right coronary cusp in the center, non-coronary lowermost, and left coronary is uppermost. This is what we want. And we can achieve this angle by looking at the cross-sectional or the transverse view. This is the transverse view where we are looking at all three cusps. The cursor or the crosshair should cut the right coronary cusp in the center. So if you now go to the image on the right top, this will give you the angle. It's LO1 cranial 1, right? So this is how we identify the fluoroscopic angle for the coplanar view. And this is how we, with the Remensho, they are all automated, right? So we need just a click, and for the deployment angle, for the right left cusp overlap, and for the autography angle. Autography angle is used to assess aortic regurgitation after the device implantation. So once we have done that, then we measure. As we have already discussed a little bit, measurements based on the annular plane, dependent on the annular plane, and there are certain measurements which are independent of the annular plane, like diameters. SOB diameter, STJ diameter, ascending aorta diameter, they hardly are dependent on the annular plane. The measurements which are important uh, is the annular dimensions, coronary heights, STJ height, ascending aorta length, alveolar diameter, and prediction of the fluoroscopic angle, which we have already discussed. So these measurements are dependent on your annular plane. If your annular plane is incorrect, these measurements will be incorrect. So it's very important to have these measurements with a correct plane of the annulus. And we all know these structures. The annulus is a virtual ring, and then we have LVOT and then STJ. These annular measurements can be diameters, as we have already seen measuring, long and short diameters, area drive diameter or perimeter drive diameter. Area drive diameter we use for balloon expandable valves, perimeter diameter we use for self-expanding valves. And the methods are, there are various methods for manual measuring of the annulus, and Tremencio does it automatically. In the manual measurements, it's very important to understand that there are, most of the softwares have these three methods. And out of these, spline method is the most correct method for assessing the perimeter. Otherwise, area-wise can be assessed by any of these methods. But for the perimeter, spline method is the most correct way. Because the perimeter will change once you have irregularities, once you have non-smooth, irregular line, like in the first, the perimeter will change quite a bit, although area will not change much. So these are the various measurement tools. Then we should look at the calcium at the level of the annulus. Annular calcium is very important. And if we have a calcium at the level of the annulus, this can be classified as crescent or non-protruding calcium, or bulky or protruding calcium. For annulus measurements, we should measure the annulus just thinking that if the calcium is not present, we could have measured in a way. When the calcification is present at the annulus, the annular contour should be traced as if the calcification was not there. So forget the calcium for annular measurements. We need to go along the annular contour. But these calcifications are important. Suppose we have a protruding calcium like on the right side, this will cause PVL, significant PVL after the procedure. This is prone to complications like annular rupture. If this protrusion is more than 4 millimeters, it has been found to be associated with complications like annular rupture and significant PVL after the procedure. Then we measure the coronary heights. I think once we have identified the plane, annular plane, then we can rotate our crosshairs in the short axis view. What we mean to say is the transverse double oblique view. And then in the other views, we will see the coronaries, right? Then we can measure the coronary height. Thus, there are like practical ways of doing it. So coronary heights are important. Again, the STJ height is the height of the distance from the annulus plane to the superior aspect of sinusoval cell. These measures are important in case of high implantation where processes may come in contact with the STJ. Ascending aorta length is again important. This is measured from the annular plane to the point where the crosshairs intersect the ascending aorta. Right? This can be done in any of these views, but they will be same. But this is usually required if our approach is transaortic. Alveolar measurements, here we have to go down into the alveolar and take various measurements like alveolar diameters, look for presence of alveolar calcium and septal hypertrophy. This is important because presence of alveolar calcification has been associated with presence of like after the procedure, the presence of PVL, heart blocks, as well as unexpanded processes. The same is true for septal hypertrophy, which may sometimes cause embolization, because if we use a self-expanding valves in a patient who has got a small alveoli in comparison to the annulus, and there's a septal hypertrophy, the protrusion of our processes into the alveoli may cause complications. Similarly, the balloon selection for pre-dilation and post-dilation in these patients with septal hypertrophy has to be cautious because the bigger balloon may cause injury to the septum. Alveolar calcification, we have already discussed. Then sense of Valsalva width. This is another important parameter. This is really important if we have a shallow or non-capacious sinuses, which may predispose to coronary occlusion. And this is done for all the sinuses like left coronary sinus, right coronary sinus, and the non-coronary sinus. In general, we say that if the sinuses are more than 30 millimeters, we are happy. But this is again relative term. If we have a small processes like a 21 or 22 millimeter size of the valve which we are going to implant, and if the sinuses are 26, they may be okay, right? So it's all a relative thing, and usually in general, sinuses more than 30 millimeters are okay for most of the procedures. Then STJ diameter is again important. It's the diameter at the level of the sinotubular junction. This is important in case of high implantation where processes may get in contact with the STJ. The sending aorta diameter, this is usually done 4 centimeters above the annular plane. This is important to look for aortic aneurysm and the ascending aorta, especially in the setting of transaortic approach. Now, another important thing is the measurement pitfalls. We have done all the measurements, but we should know what can be the errors, what can be the problems, where we can go wrong. It's important. So several factors can potentially lead to inaccurate measurements. These include incorrect annular plane. It may be wrong angulation. It may be plane which is too high or too low. This will affect the measurements, coronary measurements, or the measurements which are dependent on the annular plane. So it's important to have a correct annular plane. Then next important factor is, or pitfall is the measurements which are not perpendicular to the annular plane. They may be false. Malalignment artifacts, breathing artifacts, poor contrast enhancement, image noise. These all like factors can cause complications like embolization, coronary occlusion, aortic rupture, aortic dissection, periaortic hematoma, PVLs, and malposition of the valve. So it's very important to know these pitfalls and address them. In case you are not happy, then it's better to repeat a CT rather than going ahead with the CT with pitfalls. If the plane is incorrect, suppose the angulation is incorrect. Here what we see is the right top panel. You can see right coronary hinge point of the right coronary cusp is visible at 1 o'clock position, whereas hinge points of other two sinuses are not visible. This means that you are higher up on the right coronary side and lower down on the other two sinuses. So this is not a correct plane. So here you have to change. You have to have a measurement or a plane which is correct so that your measurements which are dependent on the annular plane are correct. How to verify height and angulation? This is the method that we have already shown you in the Singo software. That one method to verify the correct height and angle is to raise the level of transverse oblique plane until the cusps become visible. If the angulation is correct, all three cusps will appear and disappear at the same time as the annular plane is raised or lowered. So go up and down. If they appear and disappear at the same time, it means you are in the correct plane. Sometimes we may be in the correct plane, but our measurements may not be perpendicular to the plane. For example, coronary height. If it is at an angle, then it will be falsely high. So it is similar, same is true for sinotubular junction and ascending aorta length. So it's important to have particular measurements perpendicular to the annular plane. If they are not perpendicular, the measured height is greater than the actual height. So predisposes to the risk of coronary occlusion or other complications. Next important fact is irregular heart rhythms like atrial fibrillation or premature ventricular contractions. They may cause malalignment artifacts. If this artifact is affecting the annulus, is at the level of the annulus, then you can't really analyze the annulus, and you need to go back, reconstruct your images from the raw data set with ECG editing, and then analyze it again. So malaligned artifacts are not acceptable. Similarly, double contouring or blurring, they are also affect your annular dimensions and should not be accepted. Another important thing is breathing artifacts. Suppose a patient breathes during the acquisition. This also gives rise to the artifacts. And if these artifacts affect your annulus, you can't accurately assess it. How do you distinguish breathing artifacts from malalignment to artifacts? They look the same. Look at the sternum here. If you see this step, like in the sternum, right? This is breathing artifact. If you don't have this, but have these levels, this kind of levels at the annulus, right? They are breathing artifacts. If it's affecting the sternum also, if it's not affecting the sternum, they are malalignment artifacts. And poor contrast, we know that they will add to the noise and we cannot analyze the image properly, right? So this is the pitfalls which we normally get in our annular or aortic root measurements. Going to the access analysis, we all know most of the cases are done by transfemoral approach, although we can like do it transapical, transaortic, or other approaches also. So we will focus on the transfemoral. We need to assess the aorta. When we assess the aorta, we need to track the aorta from top to bottom, top to the bifurcation, to look for any tortuosity, aneurysms, particularly thrombosed aneurysms or exophytic plaques, which can embolize during the procedure. And we need to analyze the iliofemoral vasculature for diameters, for calcifications, for tortuosity, and for dissections. So for the dimensions of the vessels, sometimes what we see practically is that the vessel diameters are good, but when we try with a device, it's not going in. There is a reason behind it. Sometimes we are not able to assess the diameters properly. When we assess the vascular dimensions, they should be assessed perpendicular to the longest of the vessel. Suppose we are at an angle, it will give falsely larger measurements. So in the axial images, in the CT, when we acquire the CT, it's the only femoral arteries which are oriented in perpendicular fashion to the imaging plane. All others, iliacs or external iliac or common iliac, they are not perpendicular to the imaging plane. So we are likely to measure these vessels incorrectly. So to address that issue, it's better if we put a central line in these vessels, which is available in the softwares. Put the center line, center it properly, and then take cross sections perpendicular to this line, which will be perpendicular to this vessel. So this will give us the correct measurements and avoid the surprises in the lab. Calcifications are also important. Calcifications may be spotty. Sometimes it may be spotty just at the spots. They may be confluent like this. They may be horseshoe shaped like this, or they may be concentric or circumferential like this. Circumferential and horseshoe calcifications are significant, and they may impair our access issues, but others can be addressed as the vessel stretches to some extent. And these calcifications are very important for if they occur, if they happen to be there at the puncture site. If you have a calcification anteriorly at the puncture site, you are likely to land up in the complications, as your proglides will not take up. Although in such patients, you can use the other methods, but there's an issue with suture-based devices if you have anterior calcifications at the puncture site. So always do ultrasound guided puncture if there are calcifications, and try to avoid anterior calcifications at the puncture site or for puncture. When you puncture, avoid these calcifications, go up and down a little bit and avoid these calcifications at the puncture point. Tortuosity is again important. We may have to use hard wires. And there may be other approaches like transaortic approach or transapical approach, which may be required in case the femoral approach is not available. And we can assess from the CT whether the patient is suitable for a apical approach or transannular or transaortic approach based on the parameters which we have like here. Again, for the transaortic approach, the distance of the aorta from the sternum is very important, right? Location of the aorta with respect to sternum is also important. If the images show that aorta is central or posterior to the sternum or to the left of the sternum, upper mini sternotomy is recommended for the transaortic approach. If the CT axial view shows that aorta is to the right of the sternum or it is horizontal at an angle of more than 45 degrees, a mini thoracotomy should be sufficient. So this is the peripheral section, we all know. We need to see from the aortic root to the bifurcation, and always go through the cross-sectional images, the transverse plane from the descending aorta down to the bifurcation. Always do this. It is really helpful. It will tell you where you have aneurysm or thrombus or exophytic plaques or stenosis or calcifications, where you are going to get into trouble, where you have to be more careful while negotiating your transcatheter heart valve or W. And it will show you where is the bifurcation in relation to the femoral head. And it will show you how deep is your femoral artery. Sometimes patient may be obese. It may be really deep. If it is deeper than more than 6 centimeters, it may be problematic. It's better to go for a vascular puncture. Yeah, so, vascular cut down. Then we need to assess the risk of coronary occlusion for valve-in-valve procedures. Suppose we are planning for a valve-in-valve procedure in the aortic position. First of all, we need to assess is the pre-existing or the degenerated bioprosthetic valve is stented or not. If it is stentless, if it is not stented well, then coronary height and SOB measurements are just like the non-native valve, right? Otherwise, if it is stented, then we need to see the level of the coronary ostia with respect to the top of the stent posts. If the coronary ostia is higher than the stent post, nothing is to be done, no risk of coronary occlusion, go ahead with the procedure. However, if the level of the coronary ostia is lower in comparison to stent post, then we need to be careful. We may have to measure VTC and we may have to measure virtual valve to ST junction distance for valve-in-valve procedure. Another important thing is the capacious aortic root versus a narrow STJ. A narrow STJ will predispose to coronary occlusion or sinus sequestration, like the figure on the lower panel shows a small VTC and near zero VTS. That's valve to sinotubular junction distance. Sometimes, even if the root is capacious, what your surgical valve or the degenerated valve is canted, is tilted at the time of initial in the CT, if it is tilted, then even a capacious sinus may have issues, may have a smaller VTC, near zero VTC, and may land up with coronary occlusion. So this is again important. If your prosthesis is tilted, you have to be careful. Then tab and tab CT is another which will, I think, volume will increase in the coming years. We need to be careful. We need to be careful about the leaflet location in comparison to the native ostia. What is the distance VTC from the tab frame? Whether the previous valve has been commissurally aligned or not, and what is the risk of STJ sequestration. These are important considerations when considering tab and tab. When considering tab and surgical valve, if your surgical valve is below the coronary arteries, the top of stent frames, as we have discussed, is below the coronary arteries, there's hardly any risk, and you can proceed with the procedure. However, it's always suggested to use a virtual valve. whatever valve you want to use, it's always better to use this virtual valve in the software and assess the VTC. However, if the coronary height is lower, the risk is high. Further, CT may also help in determining in addition to determining the risk like low coronary height, narrow STJ, narrow VTC, risk of sinus castration. In addition to this, the CT scan can also provide us with angles for leaflet modification like Basilica. And CT scan also provides us the anatomy of our cerebral or vessels for embolic protection devices, whether if patient is suitable for these devices or not. So concluding, our reporting should include the information on data acquisition, timing of the images in the cardiac cycle, contrast volume, and image quality. In addition to the assessment of the aortic tortuosities, measurements of the aorta, aortic arch, then and measurements of the annulus, measurements of the heights of the coronaries, and all these things that we have discussed, they should be included in our final report. I think that's all for today. This is what we have already discussed. Then we have a Tremencio available, but although it's very expensive, and here also we can analyze it. It's an automatic software. Here what we do is, when we do it automatically, it will press this automatic button. It will bring in the MPRs. There are 3 MPRs, and then we put 3 dots at the vessel hinge points, and we can make various measurements as required. This is what we have already discussed. Measurement of the annular plane, and this is confirmation. Always confirm the annular plane once we have created it, because all your measurements depend on your annular plane. Another interesting thing is the membranous septal length. This can also be measured easily from the CT scan. And here what we see is, this is the septum, this is the septum, and this is the membranous septum, this thing. So measurement of the length of the membranous septum may help us in deciding the risk of having a pacemaker after the procedure, particularly if we are using self-expanding valves. Vascular access issues we have already discussed. So this is the final report which we normally get from the companies on Tremencio. It mentions all the parameters that we have discussed. Thank you.
Simply fabulous, Dr. Parminder. Thank you so much.
Thank you so much.
Absolutely. That was really comprehensive.
Fantastic it was, I felt like sitting down and again. I've taken down lots of notes. One thing I was wondering, the leaflet length. I wonder if you could just speak a line about leaflet length, when it becomes important.
And also about bicuspid, sir, if there is a difference with, yes.
Sure, yeah. This is absolutely a very good question, I think, because in India we have bicuspids which are more common in comparison to tricuspids, and particularly type 0. And type 0 is really, leaflets are very large sometimes. And no doubt, in case of bicuspid valves, if it is type 1A or type 1A particularly, its measurements are just like the tricuspid valve. But if it is a bicuspid valve, type 0, then possibly even the annular plane measurements becomes difficult. Some of the operators, they use 3 points even for type 0. But what is recommended in such situations is that use 2 points, but you need additional checks to define and to verify your annular plane. You need to have another check, which is, I can't tell you here, but we need to adjust the plane up and down in various views to know that you are at the hinge points. So type 0 is really a little bit difficult to assess. Type 1A can be assessed just like the tricuspid valve. Regarding the leaflet lengths, yes, leaflet lengths are very important, particularly in the bicuspids, particularly in the females, because the coronary heights in such patients are quite low sometimes. The leaflet is large. In such a situation, if the sinuses are narrow, you are likely to land up in sinus sequestration. So, in such a situation, I think it's if the patient is at high risk of coronary occlusion, either it's better, and it's a small annulus. Most of these patients have a small annulus. Most of these patients get a small valve. It's better to send these patients to the surgeons, particularly the risk of coronary occlusion is very high, or you may have to plan a basilica procedure. Although basilica procedure for the native valve is more risky in comparison to basilica for the prosthetic valves, bioprosthetic valves.
Sir, we measure the whole leaflet length from the annulus to the tip,
Yeah, yeah,
using those
yeah.
splines.
Yeah, you can measure it with there are curved lines which are in the software. When you assess it, you have various tools available. One tool available is the curved line, right? You can use the curved line to measure the leaflet length. Yeah, and if your curved line, if the leaflet length is larger than your coronary height, you need
Coronary
to be
height.
careful, especially if the sinuses are small. Because what will happen is when you deploy the valve, it will deflect your native leaflets outside, and this can obstruct the coronaries, particularly if there is a lot of calcium. So be careful. In such patients, either use a coronary protection or use basilica or send the patient for surgery.
Absolutely. It's important to remember that there was life before TAVI also.
Yeah.
So about tortuosity of the iliacs, uh, is there any objective criteria that how tortuous an iliac has to be before we say that no, we are not going to use this? Like for example, the image that you were showing, if we come back from the femorals to the aorta, after the inguinal ligament, the femoral, the artery will drop inside the pelvis and then come upwards again. So there is going to be some sort of tortuosity if we see from the side. So how much tortuous is there any objective way to say that now we can't do this?
I think there is no standardized criteria for looking at the tortuosities. Although some people say angulations more than 40 degrees and presence of more than two bends is becomes highly tortuous. But still, if the artery is not calcified, if it is simply tortuous, if it is not calcified, then possibly, and if the size is not a limitation, then I don't think there is a big obstruction to going ahead with TAVI in these patients. We can use hard wires like Lenderquist, or we can use a body wire technique. Important thing is if your sheath goes in, most of the times your valve will go in. And this is particularly true for the self-expanding valves. Sometimes balloon expandable valves have a smaller frame. They don't create much difficulty in getting into the tortuous vessels or but if it's a larger frame valve, like you have a evolute valve, which is a larger frame, it doesn't take up the tortuosities sometimes. But what I have seen is that if your sheath goes in, usually the valve goes in. Yes, you can try if the artery is not calcified, if the diameter is good, you can still try.
Right. So
Fantastic. Just one point about angulation in 1B.
Angulation in
Oh, bicuspid 1B.
GG, right? Okay. Yeah. Uh-huh. I mean, how to do that?
Yeah.
Angulation means yeah. 1B. Yeah.
Yeah.
I
Basically,
think
when
this,
we
yeah.
say horizontal, we usually use 60 degrees. But I think the 1B subset adds an additional
Yeah.
tortuosity because the nose cone has to come down and then go back up again in 1B
Yeah.
when the raphe is fused. So,
Exactly.
we usually add another 20, 25 degrees. So if it is 45, it will actually be 65, 70. And if the raphe is calcified, in that case, you start with a snare up front, for the
Yeah.
self-expanding.
Yeah. It's very
And
difficult to cross like the this kind of valves. 1B is
correct,
sometimes very
correct.
difficult to cross, as you have rightly mentioned, particularly if the aorta is horizontal.
Yeah. And lastly, the just a word about the STJ when the valve frame contacts the STJ, if the STJ is small. I think that's another subset where we should really consider sending the patient for surgery, because sometimes it's very the bailout options are very limited
Very
in
limited.
patients in who have got calcified and small STJs. So I think
True.
that is an important thing to look at.
Yes, absolutely. Nice point.
But I think the talk was simply fantastic. And, I've really learned a lot, Dr. Parvinder. You feel like you could keep talking and we could keep listening. Really
Yes, sir.
wonderful.
I think
Thank you so
we
much.
need to
Thank you
have
so much,
another
sir.
talk.
Yes.
We should
Great words
have
from.
definitely one more. I think we should go
Yeah.
one more on
Great words.
bicuspids.
On yes,
I'd really love to share his experience and, listen to him speak on bicuspids. And this is not only
microsoft.
about the measurements, but about the difficult subsets, probably. We should get him to speak on difficult subsets in TAVR, CT measurements, and, you know,
Yeah.
Yes, sir.
Okay.
And mitral valves also, if possible.
that is an entirely different talk. I think difficult subsets in TAVR are very important. Mitral, actually, once you get used to it, I find it easier than TAVR, to be honest.
Yeah.
Yeah,
Sure.
and sir took the time out to show the videos of how to select and acquire. I think that's really
Yeah,
nice of
because we can do it. Most
yes.
of, I mean, we don't know that we have these things available with us. We can do it in our software, which is available in our CT machines. Just, I mean, point is just to start doing it.
Yeah,
Once we
yeah,
get into it, we
absolutely.
will really love to do that.
Enjoy it. True. No, we've become lazy. I just put it on 312 and use the automatic tools everywhere.
Yeah, I think the advantage of doing because I mean you are experienced guy for the beginners. Advantage of doing the manual things is that we can understand the
Appreciate
problems,
nuances.
we can
Yes,
understand the
yes,
artifacts, we can understand the issues, because overall, even if you do it automated, you have to supervise it.
Sir,
yes.
about artifacts, like you were saying, I remember. So how do we understand just from seeing that it's a malalignment artifact? Like breathing, like you
Yes.
said, but malalignment, how just like grossly looking at the screen or at the
What
image?
happens is that malalignment, suppose your annulus is, you see the annulus is like this, right?
Hmm.
If it is cut, like if it is cut,
Okay, there's a
yeah,
level. Okay,
level. There is a level in the annulus, right?
right, sir.
You can't measure the annulus, right? You
Okay,
can't take measurements. You can't use these measurements, right? So
right,
in such a situation, either go for reconstruction, excluding those like images. If it is a malalignment artifact, if it's a breathing artifact, possibly you cannot do anything. You have to acquire the CT again.
right, right, sir.
Fantastic, Sojata. I must thank you for getting Parminder to speak on this. Really
Thank you,
enjoyable
sir.
evening.
Thank you for your kind words. Thank you very much.
It was really, sir. I was lucky that I was able to get and sir suggested this topic. I never actually thought that it would be so great. I knew it
Yeah,
would
yeah.
be nice, but this was really wonderful, sir. And I think the YouTube link will be helpful for PGIs and I think for others also, beginners anywhere who are starting to do towers. So, sir, if you can conclude, then we can end or.
No, I mean, I'm really struggling, but I think it was a wonderful session. Thank you again, Dr. Parminder, for having
Thank you, sir.
shared
Thank you so much.
your experience in teaching us how to analyze, how to acquire, and how to analyze CTs with special respect to Tower. And thanks, Sojatya. And I think this is one of the nicest parts of our PGI cardio group that we're able to learn from each other. Thank you so much, everybody.
Thank you, sir. Thank you. Thank you,
Thank you,
Dr.
sir. Thank you,
Sujatya.
sir.
Thanks a lot
Thank you,
for
sir.
yeah.
Thank you,
Thank you.
everybody.
Thank you very much. Good
Thank
night.
you.
Good night,
I think we
Gaurav.
can, with that, we can end, sir. Yes.
Yes, Sujata. Thank you. Thank you very much. Good night.
Thank
Good
you,
night.
sir.
Good night, sir.
Thank you. Good night.
We can stop recording netcast.
Yes,
Thank.
I think Dr. Sajita, sir.
Yes.
Yes, sir. You have the host right now. I give it to
Okay.
you, sir.
Right.
Yeah.
Right. So I'll end it here. Okay. Yeah.
Yes, sir. Sure, sir. Or if you want, you can just give me the right, so I will just conclude it, sir.
So how do I do that?
Just click on my name and make host.
Right. Right.
Yeah, thank you so much, sir.
Okay, Mr. Sharma. Okay, thank you. Thank you so much.